Welcome to the podcast of HemaSphere, the official journal of the European Hematology Association. HemaSphere's podcast presents insightful, expert discussions about recent hematology publications. We hope you enjoy.
I'm Charles de Bock, and I'm your host today for the HemaSphere podcast. And today I am joined by Dr. Francesca Tiso and Dr. Florentien in Hout from Radboud University Medical Center. Welcome to you both.
Thank you. Thank you. Hello.
Okay, so today we're going to discuss your latest work, which is going to be published in HemaSphere, which is entitled High Levels of Global Hydroxymethylation Predict Worst Overall Survival for MDS Patients Treated with Azacitidine. And I understand, Francesca, this was part of your outstanding PhD work, so congratulations.
Thanks a lot. Yes, it was one of my work. Yeah.
Excellent. And so because we have such a broad audience at HemaSphere, I thought it might be a good idea to perhaps start with having a bit of a brief breakdown for MDS or myelodysplastic syndrome in terms of maybe the clinical presentation and some of the key mutations which we might find in MDS patients.
I can take that one on. Myelodysplastic syndromes is a bone marrow disease, and patients can present with anemia, showing like in fatigue or shortness of breath. They can have also thrombocytopenia, which can cause bleeding or bruising, and they can also present with infections due to leukopenia. A wide range of clinical presentations. Some patients, most are mostly severe, inhibited by the anemia, but there's also patients who are more presenting with the thrombocytopenia. If you look into the bone marrow, we see dysplastic cells, so the cells don't look normal. They look different because they have trouble forming healthy blood cells. And sometimes you can also see increased blasts, which are the very young cells that are the start of your hematopoiesis. So if we look at the WHO classification, you can look at MDS, define it by genetic abnormalities. So then, for example, you have the isolated 5q deletion, which is a separate group of MDS patients who respond differently to treatments. You also have MDS with low blast and SF3B1 mutation, which is a common genetic abnormality, and also you can find MDS with TP53 mutations, and the biallelic one are very, very hard group to treat for us. You can also look at MDS are morphologically defined, so then you look at how many blasts are in the bone marrow, and then you can make the distinguishment between low and increased blasts, or if the bone marrow is very empty, there's not many cells at all, then you can speak of MDS hypoplastic. So that's what we use now in the clinic to distinguish these patients. Interestingly, recently there was a paper by the group of Papa Emmanuel published in Blood, and they actually can identify 16 molecular subgroups, and also their clinical implications. So there's actually way more I think to discover there to further distinguish the groups of patients. We looked at patients with TET2 and DNAT3A mutations specifically. I think we will get back to that later.
Yes.
And also this group was the TET2 mutations were also identified in those 16 molecular subgroups, where they could distinguish between biallelic and monoallelic, and they showed a bit of different phenotype. So that's quite interesting.
So in terms of treatment, what happens? So when these patients present with MDS, or should I ask, before we get onto that, what is the age that most people present with MDS?
It's older age. So most patients are over 65. Yeah.
I was going to say old is a range, right? So we better be clear that 60.
Yeah. So I'm not giving any value to it, but over 65. Yeah.
Right. Excellent. Okay. And the types of treatment that these patients, or that you would be expecting to give these patients that are diagnosed with MDS?
Yeah, so that depends on which risk category those patients are classified. So if you have low risk MDS, then currently it's at least in the Netherlands, you start with best supportive care. So you see if they can use EPO or blood transfusion. If you have this specific deletion 5q MDS, then you can be treated with lenalidomide, which patients who have this del5q can respond very well to. Almost 60-70% can show a hematological improvement with this medication. It can also be used in patients without this deletion, but then the response rate is far less. It's like 25-35%. Also, the patients who have this specific mutation in SF3B1 or ring sideroblasts that you can see under the microscope, they can get luspatercept, and that gives a 30-40% response in those specific patient groups. And for the other, at least in the Netherlands, it's not yet registered for other groups except for those. And if you have high-risk MDS, you can be treated with, depends on how many blasts you have. You can either have an upfront allogeneic stem cell transplantation if your blasts are under 10%. If you need pre-treatment before you can be transplanted, if you're fit enough and you have a donor and all these things, then you can get treatment with azacitidine or sometimes chemotherapy to reduce your blasts. Yeah.
So Francesca, in your study as well of 500 patients, you actually grouped the patients into 3 different cohorts, and that was based on the treatment they received, and that being best supportive care, lenalidomide or azacitidine, and then you looked at the levels of 5MC and 5HMC on overall survival. So what did you find across those 3 groups?
Yeah, so in best supportive care lenalidomide, we noticed that the levels of 5HMC as well as 5MC did not have any impact on the response to treatment. Instead, we found that the 5HMC had an impact on the response to azacitidine. And this is probably very likely because the other 2 treatments or supportive care do not act on the methylation level. So it doesn't matter which methylation level the patient has at baseline for the response to the treatment.
Very good. Okay. So that's a nice segue, because this is the crux of your paper is the use of azacitidine, which is a hypomethylating agent, and its use in MDS. And so I guess one of the things you mentioned is the risk score and risk stratification, and you said how the different treatments really are based on whether a patient is classified as high risk and low risk, and genetics plays a part in that. And so one of the scoring systems is IPSSR, which is used in the practice. I mean, so what are some of the challenges in that risk stratification currently in the clinic?
Well, actually, the IPSSR is our main used risk classification, and what you do need is cytogenetics. So you need to have the results of your cytogenetics. So you have a lab. You need a lab that can process that. And the other marks are percentage bone marrow blasts. So you need to do a bone marrow aspirate or a biopsy. And the others are the hemoglobin levels, thrombocytes, and neutrophil levels. I think those are all easy to acquire, but so you do need a bone marrow investigation, and you do need cytogenetics to be able to use this stratification.
So, as you said, there are now moves, of course, to move into more molecular as well with the 16 subtypes, etc. as well. So we're going to get that, but clearly there's a barrier there, because if you don't have the laboratory techniques there, it's going to be limiting in terms of how well you can apply and the utility of the IPSS score. We probably won't go into that today, but I guess for you and your paper today, what were some of the questions that you wanted to ask? And maybe I can ask you, Francesca, seeing as
I can take over.
Yes.
Yeah, of course.
What started the project?
So the project was started because not all patients respond to azacitidine, and the response is in about 50% of the patients. And at the moment, we are lacking biomarkers that can discriminate if patients will respond, but also the response to treatment is happening actually after a few courses. So we also need biomarkers that can identify if patients will respond or not earlier than what we can see. So that was the need, and this is why we started this study. And the other reason to investigate that in MDS patients is also because azacitidine acts as a hypomethylating agent, and as Florentien already mentioned, a lot of patients, MDS patients, are mutated in TET2, and TET2, when they are mutated, actually cause a loss of function in the TET enzymes, and TET enzymes regulate the active demethylation process. So methylation is a reversible process that occurs constantly, and the DNA is methylated by DNA methyltransferases that can methylate the cytosine, forming the 5-methylcytosine, which we call in our paper 5-MC. And the active demethylation process is carried on by TET enzymes, which can basically come back to the cytosine through an intermediate stage or through many intermediate stages, but the first one is 5-hydroxymethylcytosine, which is 5-HMC. And this is what we also measure. So we thought it was interesting to measure 5MC and 5-HMC because of the rate of mutations that we find in MDS patients, which is about 30%. And another important mutation that is in MDS is also in IDH enzymes or IDH genes, which encodes for the IDH1 and 2 enzymes, which are also involved in this demethylation process because they produce the alpha-ketoglutarate, which is a cofactor needed by TET enzymes. And when they are mutated, they produce a 2-hydroxyglutarate, which can inhibit the functionality of TET2. So we thought, okay, not all patients are responding to azacitidine. Many patients might have mutations in these genes that can compromise the normal process. So the levels of 5-HMC can already be impacted or can be already changed in these patients. Can this be the cause or can this be something to check? So this is how we started, and this is what we measured. And so this was the start of our study.
Okay, so in your study, you show that in previous studies, the levels of 5-methylcytosine was predictive of overall survival, but you did not find that in your study at all. And so I just wanted you to elaborate that because you put that down to the type of measurements or the methodology used to measure the levels of 5MC. So can you explain a bit on that?
Yeah, we didn't find any correlation between the response to treatment and the 5MC. Which was maybe a bit surprising because you would expect a correlation also in there. Well, one of the reasons could be that in our DNA, the 70% of the CpG islands are actually methylated, and this the methylation is not so so much changing compared to the 5-HMC, which is instead a constant intermediate phase, which is constantly changing. So probably the variation can be measured more in the 5-HMC compared to the 5MC. So maybe that's why we detected this compared to the 5.
Okay, and then the methodology that you used is HPLC mass spectrometry, right, that you used, whereas I think previous studies have often used ELISAs. So what's the benefit of using HPLC, MSMS, and I guess how broad is that, the utility of that technique more broadly in the clinical setting? Is that possible, or is it really still only in the experimental, like laboratory setting, that we can have that level of measurement to that degree?
No, I think it could really be applied also clinically speaking, because it's a quite robust process and it's a very high throughput technology in which a lot of samples can be loaded. And so that's also the reason why we chose this technology, and it's also quite reliable. It has a very high sensitivity. So,
Yeah, but what I do think is going to be a challenge in the clinic is to see what is your cutoff point. When do you say someone's high or low, or somewhere in between? So I think you definitely need, even bigger studies to determine what is normal and what is high, what is low, before we can actually draw some consequence from it.
Yes, in terms of prospectively, when a new patient comes in to say, okay, whether your level is high versus low, it's obviously quite clear when you've got a retrospective analysis and you know the outcomes, you can set your cutoffs and say, okay, these patients are early and these ones are worstly. Yeah, okay. So Francesca, as part of your PhD, you carried out this amazing study, which in this case recruited essentially 504 patients, which is a very large number. And so what were some of the challenges in recruiting that large patient cohort and also then processing the number of samples?
Yeah, so I can say I was really in a lucky position because my professor, Joop Jansen, already had the good collaboration. So this came out very easy for me. And the good collaborations were with Arjan van der Lostect from Amsterdam, and two groups from France, from Professor Michaela Fontenay and Lionel Adès. we saw in our patients, which already we had in-house, we saw already a pattern in patients treated with azacitidine and having high or low 5-HMC and how they were responding to treatment. So seeing that in a small cohort, we decided to go further and ask for more for collaborators to basically join the forces and have a bigger cohort on our hands. So I can say that challenges were on the fact on finding, of course, all these cohorts. We were pretty lucky in there because all the collaborators have actually a good database and already, let's say, a lot of information about the patients. In our hands was the measuring of the 5-HMC and the 5-MC. And the most challenging part is, of course, having a clear and uniform way to call all these patients, because, of course, coming from different cohorts, this can be confusing and it can be problematic. But once you have a tidy way of, let's say, collecting everything and organizing everything, I think, we were in a lucky position.
But then in the end, you were the one who had I'm guessing, a massive Excel spreadsheet, right? Or did you have something a little bit more fancy for all the patients?
Yeah.
No.
Yeah, we used something different indeed at the end. But indeed, we started with an Excel and then we
Brought it down.
Memories.
Yes.
That's good.
Yeah.
So
we needed to double check many times, Florentien and me, to be sure that no errors were in there. So also it was a lot of group effort to check and double check and triple check, because if an error occurs, it's really hard to find it at the end. So,
Exactly.
yeah.
Lesson. There's the lesson. So in terms of the results as well, so what you found is that 5-HMC levels or high levels do have poor prognosis for those with azacitidine, which I guess fits with the TET2, with the TET2 mutations having a better prognosis because they would have lower 5-HMC. I guess the question is, what are the regions, right? So do you have any idea on the mechanism? Is it selective methylation of particular regions of the genome which might be underlying that difference, or the difference in response to azacitidine? Or is it, a global change in methylation across the entire genome, which is important? Or do you have any idea on that?
So unfortunately, we still don't know actually the rationale behind the mechanism or how the patients with high 5-HMC respond worse. What we hypothesize is that probably these patients with high 5-HMC, they already have a high demethylation turnover. So adding a hypomethylating agent doesn't really impact the status of the methylation of their cells. Whereas the patients with low 5-HMC, so low demethylation process, might be helped by the hypomethylating agent. But indeed, it would be very interesting to see where actually these hypomethylating agents act on the genome. And that's something, I would have loved to do. And also to check the changes in transcriptome. That, I think, is something very important to do before and after treatment, because we could really see the mechanism then behind the response to this treatment. Yeah, this is something I would love to do in the future.
Yes.
Maybe.
So you've now left the lab. Now, Florentien, maybe I could ask you, so what are the next steps in your project then? Is this something you're actively following up?
Well, what Francesca just said is definitely something interesting. It's not something we're working at the moment. But what we are working at is also seeing if this phenomenon that we see in MDS is also occurring in AML. Because there's also a big group of patients treated with hypomethylating agents in AML, but we do not know if the same pattern occurs. So that's also something we want to look at. And then the next step might be to look which pathways are involved and which oncogenes are involved in this methylation, and also see if that might be different between MDS and AML.
And any idea about combination treatments? If you did have perhaps, some sort of mechanism there, like if you had AZA with something else, are there any promising, I guess, therapeutic strategies on the horizon that you know of?
Well, you know that we're already using venetoclax, which is obviously involved in the pathway of apoptosis. we are already using that in the clinic and knowing it is a very good add-on to a hypomethylated agent. So it would be very interesting if we can see the mechanism behind that, if maybe the P53 or other genes involved in apoptosis are already affected by the hypomethylating agent, and then the venetoclax is adding something to that. But there's way more combination studies going on at the moment with azacitidine, decitabine. So it would be interesting if we know the mechanism. Then you have more proof of principle to look what could be successful to add to that treatment.
I mean, I guess one of the questions I have actually is, the decitabine and azacitidine. Like, when do you choose to use which agent, and what are the pros and cons of that? You don't actually cover that in your paper, but azacitidine obviously is what's used. But is there a particular reason why you would use one over the other?
Well, in our paper, we used indeed azacitidine because there was a study where they chose that as an agent. In the clinic, we can use either azacitidine or decitabine, and they're quite comparable. We know that decitabine is working a bit faster often, so often you get a patient in remission a bit quicker than with azacitidine, and you need a few more cycles azacitidine to get your response. But in the end, if you can treat them both ways, you get the same results. It seems that the decitabine is a little bit more stronger than azacitidine. But what is nice from the azacitidine is that it's subcutaneous. It's 7 days, where decitabine can be used either 5 or 10 days. If you really want to go hard, you have to use it 10 days. And decitabine gives a little bit more pancytopenias, so a bit more bone marrow repression. So it's a little bit stronger, but therefore also has a little bit more side effects, especially in the.
But there would be no reason to suggest that the levels of 5-HMC that you see associated with prognosis for azacitidine, that would still hold true if you decided to use that with decitabine, or do you think that because that wouldn't make any difference because the mode of action is exactly the same?
Yeah.
Yeah. Yep.
We assume it's similar, and also studies show that there's not much difference between the two.
Yeah, the only difference is that azacitidine is also integrated into the RNA and decitabine is not. So, but that is more in the mechanism of action and not from the response, I guess.
So what we need to do now is find another 504 patients, this time treated with decitabine, and measure the 5-HMC levels and just double check that hypothesis, and then we'll know for sure that there's no difference in treatment in 5-HMC in the correlation with outcome. Yep. Excellent. Well, I think it's a lovely study, and I think that's about all I was going to ask.
Sure.
Okay, so thank you so much, Florentien and Francesca, for a fantastic discussion of your latest work published in HemaSphere. I am Charles de Bock, and thank you for listening to this episode of HemaSphere. And join us for our next episode, where we'll be looking at the use of NSG mice and PDX models and their utility in preclinical testing for new therapies. So thank you, Florentien and Francesca, for a fantastic conversation about your work on azacitidine and outcomes in MDS patients.
Thank you so much.
Thank you a lot.
And I am Charles de Bock, and thank you for listening to this episode of HemaSphere. and join us for the next episode where I'll be interviewing Professor Richard Locke and the utility of using PDX models for preclinical testing for new drugs in leukemia.
Thank you for listening to this episode of the HemaSphere podcast. All of HemaSphere's content is open access and can be found at www.hemaspherejournal.com. We hope you will join us for future podcast episodes.